We have about 50 people online now, so I might just welcome you to the inaugural event of the National Association of Health Protection Officers of Australia. It's my pleasure to introduce Dr. Aylward, who is going to talk to us about his investigations into coronavirus in China. So by bio, Bruce is a Canadian doctor who started his career with the World Health Organization in 1992, working on the expanded program on immunisation and on global polio eradication efforts. He is the team lead for the WHO-China Joint Mission on Coronavirus that just completed its report last week. And his report and his very candid presentations on what he found, his understanding of the outbreak in China, has certainly changed my understanding of what actually happened in China, and certainly a lot of other people who've seen his report and his presentations, and certainly the really important implications it has for how we respond in Australia. So at very short notice, we have over 50 government health protection practitioners from national, state and regional health departments. And at this point, we'll start with a brief overview from Bruce. Hopefully people have read the report or seen some of the presentations which are linked before the webinar, and then we'll go to questions. Okay, thanks very much, Bruce.
There are really three key things we were interested in that I think have relevance for the world and probably for what you're dealing with there. The first issue we wanted to understand was the severity of the disease, because obviously how you calibrate your response is a function of the severity of this disease and its capacity to cause, obviously, the societal health and health system, as well as economic issues that we're seeing arise in many settings. The second issue we really focused on was transmissibility, because what one could do about this was going to be a function of the transmission dynamics, especially given the fact that we don't have a vaccine, etc. And then the third big focus was on the impact of the measures in China. So you've seen some of this, no doubt, in the report, but let me give you a little bit of a flavor of what's behind that. I would also like to say and emphasize, Craig, the international team were, people like myself who've been in this business for 30 years, but also some of the top folk out of, NIH, CDC, Hong Kong University, Robert Koch Institute, etc. And nobody was going to put their name on anything. We were very clear from the beginning, unless there were multiple supporting, observations. There was none of this sort of, it's our gut feeling or we think. It really, everything had to be anchored in trying to triangulate data, which is important, I think, for the folks on your side to know if you're going to use any of this, especially with politicians, et cetera. So maybe first, if I could speak to the severity of the disease. There's absolutely no question that the mortality rate is greater than 1% and probably somewhere between 1 and 4%. I know there's a lot of speculation about how big is the denominator, et cetera, but there were places in China where they'd done massive testing and we could get a very good sense that we were looking at a very substantial proportion of those who actually had the disease or were infected, rather. And from that, we were able to work that the mortality rate was somewhere certainly over 1%, less than 5%, but in that ballpark. There's a sharp uptick in mortality, and I want to be clear on this. People keep saying it's the old people. There's a sharp uptick over 60, and a lot of working age people are still 60. And the other thing, of course, is you read that it's people with comorbid conditions. But if you look at the overall numbers, if I remember correctly, and it depended on the area, in some area there were less than 50, less than 20% who they could identify a comorbid condition in. Indeed, people who had comorbid conditions had a much higher odds ratio of actually dying from the disease. But there were an awful lot of people in whom there were no predictors other than age that they could die. I would also emphasize that there were a lot of people in their 30s, 40s, 50s who were dying as well. And in saying that, one of the things I spent a lot of time talking to docs, nurses, people treating patients there was like, who are these people that rapidly progress, the young people, and crash? And it was interesting because, as you know, docs always have a gut feeling. Well, we think it's this, we think it's that. This is one of those settings where people could not put their finger on it. And they said, we just don't know. And I said, well, are they smokers? Do they have asthma, et cetera? And they genuinely didn't have a sense of that. And again, that was, one of the concerning aspects. And in terms of the mortality, I'd also be careful that there's kind of two phenomena happening. If you look at the data from Italy, for example, what I'm very worried about there is they have 150 deaths, a week into identifying the scale of what they're dealing with. And a lot of those people who are dying are going to be people with comorbid conditions, and they are rapidly desaturating, oxygen desaturation. They're just getting tipped over the edge with a bit of disease, and probably other diseases would have a similar impact. But the deaths from the coronavirus lung processes, and that is the ARDS-like process that they get, these people take somewhere between 2 and 4 weeks to get full-blown disease sometimes, and to die. They can take quite a long time. So the numbers from Italy are alarming because we're looking at early numbers in the most severe criticals, but we haven't probably begun to see the people who are truly dying from the ARDS. So even those early predictors or numbers can sometimes be misleading. And I say all of this because we're concerned by that, what's the word, that narrative you're hearing out there that this is flu. One of the first things we learned, and I've become really a broken record. I was actually before I went to China and have been since, that, this isn't SARS, which was one assumption because it's a coronavirus, and it isn't flu. It's a novel coronavirus. We don't understand so much about it, but we do understand this is definitely not seasonal flu, and this is worse than the most recent flus as well. It's well over 1%. Another point I would make, and sorry to hammer the severity because everything else falls from there, how much action you will actually take. The other thing I wanted to mention on the severity is that don't underestimate the ability of the Chinese to keep people alive with this disease. I was struck, I had not worked in China for about 20 years, but the sophistication of the Chinese healthcare system now is surprising, to be modest, and extraordinary at times. Many of the facilities, the designated facilities for treating severe and critical patients that we saw in China, all of them had ECMO machines. They were running like 25 ventilators at a time, and they would have 2, 3, 4 people on ECMO. It's sophisticated healthcare, and they were getting them off ECMO after weeks. So again, I'm not suggesting you need to get ECMO machines, but what I do want to emphasize is what appears to be a relatively low overall rate in China of about 1% is a function of very, very aggressive healthcare. It's also a younger population than you have in Australia probably as well, if you look at the demographic and you look at some of the risk factors. So again, I'm hammering this a little bit, but no predictors as to who's going to progress in the young people. A substantial proportion will. A substantial proportion of your population is at high risk for mortality with this disease. And again, I emphasize that because everything really goes from there. But just like it's not flu, or certainly seasonal flu in terms of the mortality, we look at the second question we studied, and that was around transmissibility. It's also not flu. And that's extremely important because if this were flu, what they're doing in China would not be turning around the curve. The transmission dynamics just wouldn't allow it, as most people, on the call, I'm sure, are well aware. But what we found in terms of transmission, as we really studied it, it really does seem to be, first, let me say, the serial interval, how long between the infectors and infectees, is probably twice as long for this disease as it is for flu. That's part of what gives you a bit of an opportunity to act on it. The other big thing that you've seen as well is the transmission dynamics in children may be substantially different than in flu. And of course, children are a big part of what drives flu outbreaks often. The third thing that we saw in terms of the transmission there is it really seems to be a function of the a combination of duration and proximity. Now, that's common for many diseases, of course, but more so than for flu, where often you can't make those associations. But as we looked at the clusters of disease in China, we spent a lot of time doing that. It really was adult clusters where they come together in high concentrations for long periods. The family clusters, families sharing together in a restaurant, conferences that brought a lot of adults together for a prolonged period, mental institutions, prisons, a nursing home. So those were the places at risk. And when you looked at schools, again, we have to be careful with China. There were no school outbreaks, but school was closed, of course, for the spring holidays. But Singapore have kept their schools running through this. So have Korea. And even in Italy, I've talked to all of these people. No one has seen school outbreaks. Doesn't mean you keep your schools open, because we close schools for other reasons, obviously, and some of them very political, but always the concern for our kids, especially in the face of an unknown. But it's important in understanding what's driving the disease. So most of it did not seem to be casual contact. The other thing I wanted to emphasize for the group, Craig, is that there's a huge discussion out there about asymptomatic disease, and that's what's driving this outbreak. That's another urban myth. Again, if China, and what they did was really employ an aggressive case finding and contact tracing strategy with case isolation and contact quarantine, that would not work if you had, a huge proportion of asymptomatics. And there were a number of provinces that we went to where they'd actually done studies and swabbed everybody who was working in a healthcare facility. And they found that, okay, say in one of them, there was 1,500 or 1,000 people. 87 of them actually were symptomatic for the disease and were positive for the disease. 4 of those did not have symptoms at the time. But of the 4, 3 of them developed it within 24 or 48 hours. 1 did not, so it's a very, very small proportion. And that starts to give you a sense of, and there were many snippets of information like that. They gave us a fairly good sense that, this concern about this widespread asymptomatic disease is really a problem, because it's hampering people acting on what we do know, which is the majority of the disease in cases and in their very close contacts. Another point that I'd emphasize was, and it's buried in the report somewhere, it looked like about 5 to 10% of the very close contacts were becoming positive, and the close contact or developing disease. I also want to emphasize that the close contacts in China, the definition they used were people who had close contact, not just from the time of disease onset, but from 24 to 48 hours before disease onset, because they were well aware that there is some shedding prior to symptom onset, or at least when people notice symptoms. So it's important you look at contacts for at least the 24 hours beforehand, the close contacts. And that was the reason that China actually went to, depending a little bit on the province, on an actual quarantine of the close contacts, because they found that otherwise you just couldn't get on top of it. The general contacts, they would let you self-monitoring, but the close contacts, they really kept an eye on. And one last point on the asymptomatics, because I hear about it all the time, also from my own people, it drives us nuts. But, I do point out that, okay, you win, there are some asymptomatics, but there are not asymptomatic transmission chains. You will very quickly find a case. And Craig, I saw in your data, and sorry, I haven't looked at it closely, that some cases don't have epidemiologic links. In China, that was irrelevant to them. Yes, they wanted to know, et cetera, but it didn't drive their strategy as much, unless there was a really big cluster. What drove their strategy, and they really make this point, was, everyone looks at China and says, we can't lock down cities. And I keep pointing out, China can't either. And in fact, they hate the fact that they locked down Wuhan. And what they keep saying to me was, one city and a few cities around it that we did lock down, every other province, 30 other provinces in the country were managed with the standard disease control measures of, public education, number 1, make sure they know the disease. Number 2, make sure that they can get tested very, very quickly and find those cases. And then number 3, the isolation quarantine. It was only when they got into clusters, community spread situations that they start suspending all the public gatherings, et cetera. But, it's a graduated response. And China really emphasizes this. They say it's not a one size fits all. That's not sustainable and it's not going to work. You've got to have a graduated response, differentiated and tailored to a combination of the epi, the capacities, and the setting. And And that's a surprise, right? From the message from outside is one size fits all. China did all of this right from the top. And that's definitely not what happened. Everywhere we went, it was a very, very tailored response. So the last comments I would make is on their response. It definitely worked. They have definitely changed the shape of the outbreak in China, and they've done it at every province level, it looks like. That has definitely saved lives and prevented a lot of disease and a lot of economic upset. And it has also been a function of the real fundamentals. Case finding, rapid case finding and isolation, and rapid then identification of close contacts and monitoring of them. As it escalates to clusters, escalates to communities, then you have to adjust your strategies appropriately. But they did not get, they were concerned when there were no epi-links, but it didn't spook them. They just settled down. And the other thing, again, many of your epidemiologists, field epis, you'll know this, the ability to find an epi-link is more a function of the investigator than it is of the virus, and of the person who has the disease and their memory than it is of the virus. That's the other thing always to remember. And in China, this was a big, big mantra I heard all the time. And people would be challenged about, their skills, rather not their skills, but how well they've done the investigation. So, I've spoken for about 15 minutes, but I thought those key points, severity, transmissibility, and impact are really the key ones. And China never gave up. No matter what they saw in terms of transmission in an area, their feeling was, we have a societal obligation to slow this down and take the heat out of it, or vulnerable people in our population will die at a completely unacceptable rate. And even healthy individuals are going to die, and we don't know who they are. And frankly, that's deeply concerning that we have no predictors, but at the same time, it is unifying as well in terms of focus. But, sorry, I keep saying the last thing because of the context. But Craig, another point that is so important and was in China was, people forget, China actually has a very differentiated system. People are on different kinds of health insurance in China, depending on who they work for, how that functions, et cetera. And the health insurance doesn't cover everything. And so in China, right from the very beginning, when the government realized what it was dealing with, it said, look, as soon as your insurance ends, the state steps in. And it gave people confidence that, get tested, we're going to cover it, or your insurance will, or we will. If you end up in an ICU or a hospital or isolated as a result of this, you are not going to go bankrupt and you're not going to incur costs beyond your insurance. That's our job, because you have got to eliminate every single barrier you can to speed. Everything is about speed. And someone said to me, I said, look, they saved 3 days, by putting these measures in place, or 2 days. And people said, oh, that's not very much. But again, remember, when you have exponential growth, by the time you get to 5 generations of a disease, if you save 3 days, you probably brought down your cases by 90%. People forget the math behind infectious disease. Speed is everything. And China got their time from case onset to isolation down from 15 days at the beginning to 2 days at the end. That's part of the reason the mortality rates fell as well. They were getting them into supportive care faster. So Craig, hopefully that helps frame the big issues. If there's some questions, I'd be delighted to help. But the big message is you really want to try and contain this. You do not know this virus. You do not know what we're dealing with, but we do know it's not flu.
Thank you so much, Bruce. That's been really great again, and added to what you've already shared. I might start with some questions that have already come in, if I can. Look, everyone seems to think that, Wuhan was a disaster and things didn't go well, but we're learning more and more it actually did, even though it was really hit hard, they actually did a good job. And I think it peaked about, was it a week or so ago, and the numbers dropped. Do you have any idea what proportion of the population were actually infected, what the attack rate was by the time it peaked? And I guess to get an idea of how many people avoided infection or might likely avoid infection.
Yeah, a super question. When we look at just the crude attack ratios in across the different provinces, right? So this is just crude attack ratios. What in Wuhan, sorry, in Hubei, that province, it was about it was about 100 per 100,000, something like that. But if you look within Wuhan itself and others, it was up over well over 500, 600, 700. And I haven't got the most recent numbers because obviously it's gone up since I've left. But it is up in the hundreds per 100,000. That is in the face of, remember, very, very aggressive control measures. Now, when you look at other cities and provinces, it ranged anywhere from 1% or a crude attack rate of 1 per 100,000 up to dozens per 100,000. So it was very, very obvious that the province that got hit first and got out of control had, this extraordinary crude attack ratio, even in the face of very, very aggressive measures, right? Remember, they locked the whole city down, nobody could move, and they created, instead of, any community transmission, these little family pockets that blew up. But, no one's really done, and no one wants to do, hopefully, the natural experiment, because you have a completely naive population, as far as we know. And look in Italy, right? That's a population of only, I think, 60 million, and they've already got, nearly 4,000 cases, and this thing is still growing exponentially in Italy. So I would, no one's done the natural experiment, but it looks like, the growth rates are ferocious. Oh, the other important thing was, we here at WHO and elsewhere, we've dealt with a lot of zoonotic and similar diseases, and we thought, okay, look, the initial event in Wuhan was different. The exposure was different. Maybe there were multiple, human interface, animal interface events across Hubei. We have no evidence of this. We have no evidence that the initiating events there were in any way substantively different than the other provinces where they had initial clusters that blew up. And again, it just comes back to would not underestimate what this disease can do and how it can spread.
So 500 per 100,000 sounds like a lot in one way, but it's not, 10% of the population. It's not 20 or 30%.
Yeah, okay, so let's look at it another way, Craig. When you look at the secondary attack rate in households, we saw numbers that range from about 5% to about 50%. And when we really dug in and tried to look at who had done prospective household studies, because I always worry about, cluster investigations, it looks like the attack rate's somewhere 10, 15%, 5 to 15% in the population. But again, this is in the face of very aggressive measures and a very, very educated population. Everybody wearing masks, nobody touching each other. So, there were a lot of things happening there. So I'm really reticent to say secondary attack rates are truly that low, or that the overall crude attack rates are as well.
That's where I was going. I guess, 500 per 100,000 doesn't sound high, but that's under those conditions. And if it was to be let go and you did have 10 or 20, I mean, with the pandemic, we wouldn't be surprised with a 30% attack rate with something in a population. So Hubei avoided that, but are other countries at risk of doing that natural experiment of seeing 30, 40% attack rates and then with the accompanying death rates?
Well, it's interesting. I think Italy has shocked the West a little bit, even then though they say, oh, that's Italy. But, this is happening in the northern part of Italy, which is usually the stronger part of the systems, et cetera. And, there's a number of factors about Italy. First of all, is they clearly have exponential growth, and it's continuing days after they knew about it. The second thing is the mortality rate. Mortality rate, the crude mortality ratio at this point is over 3%. And there's a lot of mild disease in the middle of that as well. So, but in Italy, it's funny, Craig, and this is what shocks me a little bit. For 10 years of talking about pandemic preparedness, here in Europe, we're finding countries are saying, we're not sure we can do this. Sorry, you have 100 cases. What have you been preparing for? Because any pandemic scenario has got a lot more cases than that. This is the time you dust those plans off and you look at, your worser case scenarios, not your better case scenarios. And there's no vaccine, 2 months away.
Great. Thank you. Look, some questions that we've had come in. This is a question from Dave Durheim. Given that the epidemiological data from Republic of Korea is one of the best quality sources in the world, with a major epidemic outside China, you said they've invested heavily in high quality surveillance and high level containment activities. Is their data providing early optimism that intensive public health responses can lessen the social, economic and health impacts on a country?
First, with no disrespect to our Korean friends, Dave, I'm a little surprised at the confidence in the system there. You'll remember the MERS outbreak just a few years ago there, which was devastating in the capital city and ran, for weeks with what was 128 dead or something. I mean, one of the worst MERS outbreaks we've ever seen. Huge trouble getting that under control and getting a grip on it. And in this outbreak, I actually know the Korean situation fairly well. And one of the people with us was the person who had led the outbreak response to MERS in Korea and has been a big part of it since it went back. And that was pretty chaotic. And they had a lot of problems, in part because of such a secretive religious sect, as you know, that had the initial explosion of cases in Daegu and then spread to other areas. It's only in the last couple of days that they've even been able to get the information sharing from that sect, which is part of the reason the growth has continued there. But they've had great trouble. They've also been very secretive about what's actually been the fate of a lot of people there, because one of the things that would strike you is, wow, that looks like a very high case or low case fatality rate. Simply not clear. Not unlike Iran, where we know we've got thousands of cases, but the data are still shaky. In Iran, the problem's a little bit different. But in both places, they're having real trouble just getting their information organized. They get overwhelmed so quickly. I do think there is a positive sign in Korea, and that is they had this widespread, this was a mega cluster, and because it was all fairly connected still, even when it got into the thousands of cases. But then it started to overlap with other clusters, and that's when I really say, okay, that's community transmission. Yesterday, the chap I work with there, who can be quite cynical about it, he wrote back and he said, look, these declining cases we're seeing all of a sudden suggests to me that we actually are getting a grip on that. So that is a positive thing, Dave, and that suggests that even with that large-scale, multiple facility, multi-foci outbreak, you can still slow this thing down.
Great, thank you. Questions coming in about at what point do you begin, what level of clusters or cases do you begin to close down mass gatherings and schools, universities, etc.? Is there any simple algorithm for that?
Yeah, my opinion is changing on this. It's evolving. And I actually think you have a low threshold for stopping mass gatherings. And there's a couple of reasons for this. One is obviously to reduce the amount of disease, etc. But the second is if you just think through the programmatic implications. If you let people continue to hold very large gatherings, you get 1 or 2 COVID cases in that, you're going to expend massive resources just trying to figure out how many people were actually close contacts, who actually was, etc. So the smaller the gatherings are, even before you've got substantial transmission, the easier it's going to be for you guys as the EPI and the public health experts to be able to manage it. So I would be thinking of it as a little bit no regrets in terms of the disease, but also in terms of facilitating your response. So I would have a relatively low threshold. You get a number of cases in an area, you're not able to link them all quite tightly quickly. I would say be talking to the state leadership there saying, look, should out of an abundance of caution and not to get into trouble and swamp our system, let's reduce this. Because in Italy, for example, one of their really big problems now is they're going to have 4,000 or 5,000 people clogging up their healthcare system and their isolation beds and public health system for the next month. Because these people don't get better and go home in 2 days. They're going to shed virus for 2-3 weeks.
Thank you. So just to follow up to that, say you identified an area where you had community transmission, unclear of the links, falling into, say, to a 3 kilometre by 3 kilometre area, or 5 kilometres by 5 kilometres, something like that. Do you close down schools just within that area or events in that area, or do you go another, circumference out?
Yeah, I think you want to go wider, very, very definitely. And with the schools, remember, we have no evidence that the schools are driving the transmission, and some places have left those close open. And one thing I find is that, it's often easier to close schools than it is to close, cut down on all these events you've been planning that bring thousands of people together. But it's those events that are going to drive your transmission and complicate your response, because people are going to get in there, they're going to get affected, they're going to go all over the place. Look at that convention or conference in Singapore, right? What a mess that made, because, it's a relatively small convention. These people are all packed in the same room for a while, and then a bunch of people incubated this disease on airplanes to the UK, to France, et cetera, and boom, all of a sudden you're dealing with many more foci than you want to. So I would have a low threshold for stopping events that are going to be getting the adults together for long periods of time in large numbers. I'd have a much lower threshold for that than I would for the schools. But again, anybody can challenge much of the things that I'm saying, because we're making these on, it's a thick hedge, and we're getting little glimpses behind that hedge of what's going on. But I would be really focusing on those things that are driving this. Your cases, your close contacts, and then that adult population, that seems to be the big driver.
Okay, and how would you rank, say, universities and workplaces in terms of closing them down?
I would be following the data, and I would be looking at, is there evidence? Because curiously, we've not seen a lot of university outbreaks. In fact, I can't think of one, which is a little bit curious. And again, part of this may be artifact in that China had closed all of those, as had some other places before things got out of control. For example, in Italy as well, as you know, they've closed all the schools and the universities. I don't know all the data from Italy. I know a little bit because I'm in contact with folk there, but I have a sense that they had a sense that things were a lot further than the numbers were telling, frankly, and that the testing, remember folks, the testing is always a block for people. And, they're testing the severes and not the milds because they don't have enough capacity sometimes. But they have a gut feeling there's a lot more disease. But I spoke to Italians a lot, and one of the big drivers for them on the schools, by the way, is there's such a link between the older population and the children. The children come back from school, it's the grandparents to take care of them, et cetera, et cetera. So they were really looking at it from a risk to the older population perspective if these kids were carrying the virus back. And of course, there's no reason they shouldn't be. That's why I'm always cautious about the schools.
Excellent, thank you. Now, let's throw it open to anyone who wants to put their hand up in the chat area there in the question and answer section as a participant, or submit a Q&A through the bottom of the screen.
I can see the questions, I realized.
No, you can see, yeah. Maybe while that's happening, if anyone wants to put their hand up, please do so. Quarantining of healthcare workers is a big issue. We did an exercise today and we're discussing the impact of that, and just wondering, you can knock out 40 healthcare workers with one case if they're unsuspected. Is there a way of balancing that, perhaps through shorter quarantine or, enforcing surgical masks on the healthcare workers? Any views on that?
Great question. I actually should have mentioned, we always talk about what you do when you actually get the disease or get a case. And the reality is we have to be talking even more about what you do before you get cases, because even in places where you think you've got community transmission potentially, you've got an awful lot of areas that are not yet affected. And one of the most important thing, of course, is keeping your health system running, as clean as possible. And Craig, something that has surprised me is that people have not been drilling the IPC measures in their hospitals as part of over the last month and a half. It's good practice anyway, and you've got to be drilling your IPC everywhere. So the big things I would focus on in the run-up, before you get infected is, first and foremost, your population. Your population has got to know this disease. And my biggest concern is people are not talking to their populations like adults. They're cherry picking the best possible survival rates, the best possible outcomes, the lowest possible incidences, it's just not helpful. You're going to compromise your confidence in your population before you even get started, because they read the news, they can get on and see all of our data, they read our reports, they have a sense, and then they get on social media and you lose control of the narrative. But your population is your surveillance system, as you well know. They're going to find the disease faster, they can move faster. So you really want to get your population with you, and you want to tell them, this is what the disease is. It's a fever and a dry cough. It's not a runny nose. It's not just a sore throat. It can be, but that's less than 4%. It's really fairly clear. The second thing they have to know is, where do they actually get tested and how? And, you know, I keep seeing people recommend, well, call your GP. You know, have you ever tried to call your GP? Nobody answers the phone. And then they go golfing on Friday, and then they're closed all weekend. You have just created 3-4 new transmission chains. You know, you're creating barriers. And, you know, every state or in Australia will be different, every municipality, but you will know what works for you, how you get the population to report quickly, how you get them to test quickly. In China, one of the things that they realized very, very quickly was they had to separate those people who thought they might have disease, obviously, from everybody else. So they set up fever clinics. And what happens is these people go there, the people who are there, they know how to take a rapid investigation, they know how to, you know, take a temperature, et cetera, know how to do exposure history. And then they decide, does this person need a swab? And does this person need a CT? And they CT them, same day, right there. And China's system is pretty remarkable in that regard. And then they make a decision. Is this a suspect that we need to isolate alone, not in a group, obviously? Or is this someone we can send home? Or is it potential contact, et cetera? But they do that in a way. And then when you enter a hospital, you get screened. You don't get into a hospital unless you've had a, you know, quick temperature check and the like. And they subject their healthcare workers to the same thing they subject their the rest of their population to. Because, you know, there's also this sense that somehow healthcare workers are protected, whereas, you know, they can walk in any door of the hospital, whereas the other patients are at risk. And that's not true. In China, 50% of the healthcare workers got infected in their homes, not in the health facility. So they had to keep an eye on those as well. So the IPC is just a huge piece of it. Craig, another thing to be aware of in China that they did was they designated which hospitals were going to deal with the COVIDs, and then they made sure the population knew that as well, so they could keep those separated. So, sorry, I got distracted there for a second, but the IPC, you know, a huge piece of this. Your population, you know, is your whole system, but even now, population should know what's going on. The other thing I would suggest, and it reflects some of the questions asked, is tell your population, look, when we have a few number of cases, here's what we're going to do. We're going to find those super fast. We need your help on that. We got to find their close contacts, because 10% will have disease. So we got to quarantine those. And then explain to them, if we get broader stuff, we are going to have to do Y and Z. You know, just, you guys know this, but we always forget in the heat of battle, right? Tell them where you're going. Bring them with you. So but I might have missed your question on quarantine because I got off on the tangent.
Yeah, that was all fantastic. So I guess if you've got COVID dedicated hospitals and your doctors and nurses are working mainly with COVID patients, does that mean it's not such a big problem if they work even after exposure? You know, so they're surprised, or they...
No, yeah, no. They pull them out of the system because they're going to become part of the problem as well. And they quarantine their close contacts as well, and monitor them very quickly. You know, the reality is these people will shed for a day or 2 days before they get symptoms often, not always, but often. They may not be coughing, right? So they may not be as infectious, so to speak, but they are going to get just more of your system. So you just got to bite the bullet and deal with it. The interesting thing though, Craig, is the nosocomial aspect seems to be a lot easier to manage than it is in other diseases, and flu, for example, because again, I remember when the nosocomial data, not the nosocomial data, the healthcare worker data came out from China, and everybody, you know, was like, oh my God, 3% of cases are healthcare workers. But for a disease like that, that was actually relatively low, and most of it was early when they didn't know what they were dealing with. the shock is, why in Italy did they have, nosocomial disease? Like, come on, you've known about this for 6 weeks, guys.
Let me just go to Stephen Corbett. He's from Western Sydney District Health Centre. He's got a question. Steve, you want to go ahead?
Yeah. Hi. Can you hear me, Craig?
Yeah, it's good.
Yeah. One of the main concerns I have is that China obviously was able to enforce quarantine because of its political structure, and also because of the enthusiasm of the populace for doing that. The whole strategy of containment by testing contacts is premised on the fact that quarantine will be effective. Quarantine and isolation will be effective. I just really am concerned that we won't be able to achieve that. I'd be really interested to hear what you think, Bruce.
Yeah, really good point, Stephen. And this is where it's got to, even in China, they would say, look, this has got to be context specific. I think the big thing that China had going for it was not fear of government, frankly. They had two other fears. Their first fear was the virus, because they knew what it could do. The government did not soft pedal that this is like flu. They didn't soft pedal that. They said, look, this can kill a substantial proportion of our population, and they appealed to that personal concern people had, but also that moral sense of that we have vulnerable people who are going to be at risk. Everybody has grandparents, older aunts, whatever, and also they themselves are at risk of dying because we don't, more than flu, because we don't actually know why they progress. So the government, first of all, they did not soft pedal the severity of the disease, and that was really important to getting your population to work with you, obviously. The second thing was they adjusted it to the circumstances. Oh, sorry. The second big thing that they had going for them was in Asia, again, not the fear of government, but the fear of failing to play their role, responsibly. And it's a little bit what you alluded to, Steve. I was so stunned in China. Again, I've not been there for a while, but by the sense of personal duty to the greater good. And it's just an ethic in the Chinese people and the average Chinese. And, everyone gives credit to the authoritarian government for doing this. And I'm saying, like, do not diminish the average Chinese and their sense of society. Because it's something from the outside that was truly stunning. And I come from a little island in Canada where we have a similar ethic. So you can kind of recognize it, like, wow. But the other thing, Steve, and this is really important, that they would adjust the strategy to what it took to bring the population with them, right? So, okay, if people aren't going to be quarantined, then you try and quarantine them, at home if they have to. China was trying to do centralized quarantine, and people did cooperate that. But if they didn't, they would try and do the home. They would look at the home-based care if they had to. They did create options, and it was, as the options failed, because many of those failed, they would educate the population, show consequences, and get greater buy-in for, stricter. A lot of the measures in China were made more strict as the population came to understand the severity, the damage of it, and the fact that other measures just didn't work. So, the big thing was just bringing them with them, but they did adjust them, and that's the point I would make. Your population, folks, you're going to find individual ones that say, I'm not going to do that, and your goal is not to force them into quarantine. Your goal is to force them, is to negotiate that person how he doesn't or she infect anyone else, right? While we learn whether or not they have the disease. And one of the other things they did was, source control is part of your strategy, right? So you mask your cases when you're taking care of them. Mask the contacts as well. Just think through those parts of it and negotiate it, because your goal is to bring them, get that risk down, not to zero, because you can't always. It's a really good point. And I guess you know all that, Steve. I know. I'm just reinforcing.
No,
yes,
really
that's
helpful.
Okay.
I don't know that. That's very helpful. Thank you.
Yeah, because it will work. The other thing, remembering, I made this comment earlier. Controlling infectious disease outbreaks, it's math, right? At the end of the day, you don't have to find every single transmission chain. You don't have to stop every single contact, etc. With a what is an R naught of around 2.5, you probably got to stop about 70%, 80% of the transmission chains, somewhere in that ballpark. I can't remember it exactly. But so there will be gaps, there will be holes. We just want to minimize those, right?
Right. Thank you.
some of the other questions, and I think we'll stop very shortly because you've been very generous, and I know you've got lots of other things to go to. Let's see. Question about healthcare worker, significant rates of healthcare worker infection. You've said that 50% of these infections occurred at home. Why were the workers getting infected at work? I guess it's saying another 50% were at work. Was it phobias, PPE? Yeah. What else?
Yeah, so we did speak to people a fair bit about that, especially in Wuhan, because a lot of the cases were there. And they said probably three factors were really contributing. First one was the rapidly escalating cases. People were walking into facilities, they weren't prepared for it, and a lot of it was happening in the non-designated facilities. So could be traditional Chinese medicine facilities, et cetera, because all of those counted, right? So the TCM places, people went walking into those and there was no IPC, and it's a combination of kind of culturally as well as just a lower awareness perhaps. So that was one thing. The second was, and they're very honest, they say, look, we had real problems with PPE supply in places. And then the third thing was, there was just some bad behavior. And they had in one case, they pointed out, they had a healthcare worker, knew he was asymptomatic or knew he was symptomatic, but, thought it was just overwork, exhaustion, and was sitting around in the lounge infecting other healthcare workers, for a few days. And, that was the third point, which was really important one. People are exhausted in China. The team I was working with, every time we get on a bus or a plane or a train or anywhere, a car, you turn around, they were out like a light. They were sleeping 2 hours a day and same with the healthcare workers who were in facilities. And so they got sloppy also, and they confused the symptoms, prodromal symptoms, et cetera, for just sheer exhaustion. But, if you look at today, very, very low rates of nosocomial infection. And by the way, it was interesting, Craig, in facilities that we went to, they actually ran surveys with their staff to ask, how many of them actually felt confident that they had the right equipment, the right knowledge, et cetera, and they kept making adjustments. And when I asked, and remember, this was 6 weeks into it, they said, well, in our last survey, only 90%. And they said, that's a problem. We need 100%. We need 98% feeling confident. And it was 90%. So China, there's so many misconceptions from the outside, but the Chinese are very, very human. They're good folk.
I'm sure the Chinese are very, very human.
People seem to forget that. I've been surprised coming out of the country, right?
It's just that point about hospitals being designated. I don't know that that's going to happen in Australia, that's in planning, and people might want to offer that up in the chat if they are doing that in their jurisdictions. But how important is that?
It became super important in China because they had their whole focus was keeping, saving lives. You heard that everywhere, saving lives, saving lives. And what they realized is these severe patients, the ARDS patients, they're complicated and they're hard to keep alive. So they had a strategy, and anyone who managed their way through that 40 pages of a document may have found a paragraph there about the 4 concentrations. And so a big part of their strategy was concentrating the expertise, the patients, the resources and treatment, the available therapies in designated sites so that it wasn't all over the place. Now, part of this was to help with the IPC, reduce the infection risk to your hospitals, et cetera. But the main goal was to save lives. So they were designating facilities to save lives. That was the big, and they found very rapidly that worked. So even in areas with low numbers, they made designated facilities. But the other thing they did was those places were reference centers for any other place trying to deal with it, because you would have, it's a big country and they have a lot of rural areas, but you really use technology to link up in real time with the rural hospitals to walk them through by the experts. So these people, they'd be in treating patients for like 4 hours a day, but then the rest of the time they were online like this, walking peripheral hospitals through their case management of individual cases even. So that was a big part of the designated hospitals and the concentration. And just yesterday, I spoke with the folks in Lazio in Rome, or Rome in Lazio region in Italy. And they said, look, we've got 10 cases in hospital and they're in 10 different hospitals. And I thought, oh my God, seriously? that's what you don't want to end up with, because some of those places aren't going to know what to do with these. They're going to get in trouble. The patients are going to do poorly. But again, it depends on your setting, right? And Australia is a big place with a lot of space, and you may not have that luxury. One point I would make, Craig, is when you think about your hospitals, don't think about how many beds you have. Think about wards. And in China, one of the things they did was at the front of a ward, they would basically put up a wall, put a window in it, and they would, you know, in 12 hours, that ward with 2 isolation beds, you know, 30, 40 beds, 2 isolation beds, became a 40 isolation bed ward. They would have a clean and, you know, dirty channels, etc. But they would wall off a whole ward, big window there so you could still see it and people could see out. But that's the way they thought, right? How do you quickly isolate 40, 20 people, not 2? You always have to be thinking, how are you going to get to your next level? Because as you go from cases to clusters, you're going up an order of magnitude, right? You're not doubling. As you go from those to community, you're going up another order of magnitude. That's the way, you know, you have to think and help your hospitals think.
Fantastic. Is there any last questions? Anyone want to put their hand up to ask a question before we close? Okay, we might let Bruce go. If people want to stay on and talk for a little while, that's fine. I just want to say thank you so much, Bruce. I think you've changed a lot of minds and given us new insights here that we didn't have before. And I suspect you might have saved tens of thousands of Australian lives through this very brief webinar. So thank you very much. Really appreciate it.
That'd be great. You know, just a little note from my side, Craig, when you asked to do this, Australia was very, very good to me when I had metastatic melanoma 15 years ago, and you guys took care of me, and I'm still alive. I owe you guys a lot. You never forget those things.
Well, I'm glad we did. Thank you so much.
So, cheers.
Okay.
And good luck, folks. If there's anything I can do as you go forward, Craig, very, very happy to help.
Thank you very much.